It's a pleasure to introduce our second keynote speaker, our speaker is Professor Saul Faust, who's Professor of, as you can see, Professor of Paediatric Immunology and Infectious Diseases and Director of the NIHR Southampton Clinical Research Facility. Saul has a very active research portfolio bridging the clinical and laboratory interface in infectious diseases, immunology and respiratory disease, together with early and late phase clinical trials, including vaccine trials. And Saul was recently awarded the OBE for his work leading the Cough Boost study, which, as many of you will know, played an enormous major role in shaping the UK COVID booster programme. So it's a pleasure to welcome Saul to give us a talk on the treatment and prevention of paediatric and neonatal COVID-19 and what this means. Thanks, Saul. Thank you very much.
Thanks. Thank you, Andy, and thanks to Chris and Kevin and others for inviting me. So when I was invited to give the talk, I did sort of remind Chris and Kevin that as a non-neonatologist, in the midst of all the pandemic trial work still, I would have little time to really think about the neonatal work, and they assured me that actually that's not what they wanted, and they wanted to hear a general overview about paediatric COVID, a little bit about how it might relate to neonates in future. And something that has come up since I was invited was how we might move forward, if you like, from the regulatory and investigator perspective in thinking about what the pandemic experience means for clinical trials in the future. And I think that perhaps is going to be the most interesting part of my talk, because you might well know most of the other stuff, although maybe not have seen it summarised all in one go. I'll just put up my disclosures for work during the pandemic and that I'm presenting here. And I'm going to talk a little bit about the clinical presentation and treatment of COVID in children, talk about COVID vaccines and a little bit about how they, about immunisation of children for COVID-19. And then, as I say, I think the most interesting part for me, and I hope for you, will be thinking about how we use this experience to make clinical trials better for children and families. So nobody needs reminding that the pandemic came about early 2020 with a new virus that for most people was immediately clear, became clear within weeks, for most people that it was self-limiting, but that some, particularly adults and elderly adults, were hospitalised, which was because it was a pandemic situation, overwhelming health services in the countries where it impacted, and there was a 10 to 20% mortality at the beginning for hospitalised patients, up to 40 to 50% for people who were ventilated early. For children, even right at the beginning, there didn't seem to be much of a problem, which I guess was good because it meant that the world didn't panic quite as much about their children, because you can imagine all of us what would have happened, or how it would have played out if children had appeared to be more badly affected at the start. But although this was clearly true, many people seem to struggle to believe it, especially as the transmission patterns did not fit other common respiratory viruses. People just assumed that, like flu or RSV, children would be the transmission vehicle for COVID, and that hasn't played out. Children's transmission follows that in the community. I'm not going to talk to transmission in the detail today. It's not really a controversial subject, apart from on Twitter, where there's a very loud group of people still who think that children are an important transmitter. But even John Edmonds and modelers at the London School will now agree that school transmission is only a tiny part of the overall transmission for COVID. So children represented a tiny portion of people with COVID-19 at the beginning of the pandemic. This is data for the first year. Actually, this is August 2020 to April 2021. And you can see children down here right at the beginning. These are the hospitalised children from the Isaric COVID-19 UK COSIN cohort. And you can see that tiny numbers here, slight preponderance of males to females overall, but there's also a little bulge in women of childbearing age, which was interesting and relevant to people thinking about COVID and pregnancy and the impact on babies. So the death data reflected that in waves 1 and 2. There really were very, very few deaths due to COVID in the United Kingdom. And lots of people showed that. This is ONS data a minute ago. This is data from put together by Sunil Bhopal and colleagues led by Newcastle. But right, in the first two waves of the pandemic, first wave of the pandemic, sorry, this was a very small impact, and paediatricians were saying this as well in the UK, Europe, and elsewhere in the world, apart from the United States. Colleagues from the Isaric cohort, including Olivia Swan, put together a description of children in the first wave of COVID-19 and looked at the 651 who'd been registered in the cohort, young people aged less than 19, and they reported pretty much respiratory COVID-19 in a very small number of children and the new inflammatory syndrome, confirming that severe disease was rare and death exceptionally rare in this very large prospective cohort. So I won't go through the symptoms. They've changed, and clearly they were different, like all respiratory infections, different in children, more non-specific symptoms in children than in adults, as well as the classic symptoms. And in the first waves, 3 distinct clusters of clinical phenotypes were noted for children who were unwell with COVID, a discrete respiratory illness, an inflammatory syndrome, and much rarer, and something that seems to have gone away, a very rare neurological cluster of seizures and confusion. But the inflammatory syndrome was clearly present in this cohort. And at the same time, there was quite a lot of concern about who should shield. Again, there was anxiety. Well, OK, if children aren't really affected, what about the immunosuppressed children? What about the vulnerable children? And all the data that has come out, apart from the most severely immunosuppressed children perhaps having bone marrow transplants, and in your world, some neonates, all children, regardless of their immunodeficiency, really didn't appear and don't appear still to be impacted badly by COVID-19. From a public health perspective, this has caused us a problem because, quite reasonably, as the Chief Medical Officer, Chris Whitty, took the view that actually we couldn't treat clinically vulnerable children with conditions any different to clinically vulnerable adults. And so that the shielding instruction was given to children despite paediatricians and despite paediatricians in specialties agreeing and having a nice guideline that said, this could be an individual basis. You don't necessarily need to shield. The NHS kept on sending text messages to families with named conditions, telling them to shield. And this meant that even yesterday in my clinic, I was asked to see a neurodisability family who are still shielding with a 4-year-old now who's desperate for vaccine. And the dad says he won't stop shielding until the child's given vaccine, even though that child's no more at risk than any of your other babies who've come off your neonatal unit. So it's still a massive problem. But children with immune problems weren't badly affected in any of the cohorts, not just in the UK, but in Europe as well. And led by Hans de Graaf, one of our studies led from Southampton, but a national urgent public health study, was the immunocovid study that 46 UK centres took part in, enrolling 1,419 immunocompromised children and their families who filled in a weekly questionnaire. It was hard to get any lab data. We tried long and hard to work out whether we could do blood tests, but that just wasn't going to be possible. But there was a really good uptake and consistency about people who were worried about the pandemic and SARS-CoV-2 infection, and who did fill in weekly questionnaires. And this was really reassuring, because although clearly a lot more of these children probably had COVID than we proved, because testing was in its infancy at that time. There were very few hospital admissions or worrying things about this group. Nobody was being sent into hospital, and when there was a lot of anxiety. Actually, that was the biggest finding in this study, was that 2/3 of the people within the study were incredibly anxious, and anxiety levels stayed high throughout the first year of the pandemic. When we updated the data in May last year, there was still over 1,000 people filling in questionnaires. We'd only had 5 admissions with COVID up till that point, self-reported, of this cohort. So, there was a prospective data that children really weren't being badly affected by COVID-19. What was increasingly clear, and this slide is from around June 2021, was that globally there was a massive anxiety about the hidden risk to children, with reported increases in domestic violence, unemployment, lockdowns, and poverty. All of the things on this slide are being, or were being, and are being impacted by COVID-19 lockdowns, and the focus really on adults globally during the pandemic. And even this week, the Institute of Fiscal Studies have picked out these data from the Office for Health Improvement and Disparities report from the end of last year, showing that the percentage of children above the expected level of development at 2 to 2.5 looks as if it's going to be lower in 2021 than in 2019 across all domains of development. So even on a sort of bigger data level, this is a real thing, and not just impacting school-age children and people who had to go to school, but the youngest children who are probably the most vulnerable, as you know better than me. So the UK response to the pandemic, I think we can all, and I'm sure many of you were involved in the work, even within tertiary neonatology or secondary neonatology. The UK response to the pandemic was globally leading from a research perspective. No other country has a health research system that was able to work together and deliver trials that gave us treatments, diagnostics and therapeutics for COVID-19. This was across primary and secondary care. And of course, the big platform trials are listed here. And we had the opportunity as a paediatric community to consider right at the beginning taking part in the recovery trial, which was an inpatient study for adults with COVID-19 when it started, and REMAP-CAP, which was the intensive care platform trial. And quite quickly, our intensive care colleagues, led by Mark Peters at the Institute for Child Health, had conversations with Tony Gordon at UCL and decided that for the number of children on intensive care, because the primary protocol was led from Canada, not the UK, even though the UK were doing most of the work for REMAP-CAP wasn't going to be the right study for children. And because recovery could admit children from intensive care or from hospital wards. And so we had the opportunity to bring together a national paediatric working group in April 2020, so only a month after it got going, to consider how we could include children in the recovery trial. And I present this bit on behalf of everybody who's listed later as part of that working group, including neonatologists, Paul Fleming, Chris Gale, and Charles Rower, and a bunch of other people from my world and general paediatrics. So the thing about recovery was that it's embedded in clinical care. It's low risk from a child perspective. Initially, it was using repurposed drugs. There's no requirement for GCP, for PIs, or staff recruiting patients, although some trusts ask staff to do that just for their own internal governance procedures. It had full regulatory, ethics, and MHRA approval to do that and to not have people doing that level of GCP. And it was perhaps the first big platform trial to right at the beginning, agree to input data from the NHS digital systems to support trial outcomes. But that's been fantastic. Not so good for paediatrics, as I'll explain later, because that's where we're stuck with getting our paediatric data out. But at the beginning of the pandemic, that was truly innovative and practice changing. So Nick Bishop and the people in the college, Simon Kenny and NHS England, and pretty much all the specialists involved in COVID were a bit worried that people had started to use experimental therapies on children, on the very, very small number of children admitted to hospital without being part of formal clinical trials. And so the Paediatric Recovery Working Group was formed, and we found a very strong ethics committee support for a unified all ages protocol. Amazing. Not just a paediatric specific protocol, but the same protocol adjusted, amended to include paragraphs for children, was approved on the 24th of April 2020. Only a few weeks after the adult trial had started recruiting. There was a decision to use the RCPCH treatment criteria to guide the decision about treatment, i.e. most children got, even if they had COVID, were sent home without needing any treatment, maybe a little bit of advice to the parents. So the idea was not to enrol them in the trial, but to enrol the children sick enough to need escalation of care. And at the beginning, we had the same interventions as adults with age-appropriate limits. The first randomisation included dexamethasone, azithromycin, and Kalecha, lopinavir, ritonavir, and randomisation 2 for the most seriously ill respiratory patients for adults at the time was tocilizumab, and that also turned out to be one of the treatments that we wanted to test for the paediatric inflammatory syndrome. The steroid drug, hydrocortisone, and dose was different for neonates and established by Mandy Wan, the paediatric CRM pharmacist based at the Evelina, who's been our trial pharmacist all the way through for children, and our 3 neonatologists. Tocilizumab is only for people aged 1 year and above. So around the end of April, literally about a week, 2 weeks after we got going and got the ethics approval for children, it became clear from colleagues in London that a new inflammatory syndrome seemed to be associated with a post-COVID syndrome. Now, some of those children improved with no treatment and others were more unwell, requiring intensive care and immunomodulation. And we conducted, led by Simon Kenny's team, Rachel Harwood up from Liverpool, who was actually a surgeon, on to comment to Simon, an NHS England RCPCH Delphi consensus process to establish the national management guidelines and, importantly, assess the equipoise for clinical trials and entry to recovery. That was published in Lancet Child and Adolescent Health, eventually in September, but had already had this impact for the recovery trial. There was strong support for entry to recovery, for amendments to recovery to include both PIMS and for the phenotypes of PIMS and respiratory, and to use methylprednisolone or immunoglobulin as first-line treatment for PIMS. There were statements about the more severe form of children who need escalation from steroid or immunoglobulin, and that all families should be approached for inclusion in research studies, including the paediatric Imperial-led Diamond study, which is looking at the mRNA signatures for COVID-19 and different phenotypes, led by Mike Levine, but including adults and children for COVID-19, and importantly, the AZARIC CPP hospitalisation protocol, again, led by a paediatrician, Callum Semple, from Liverpool. And also, slightly, I suppose, irritatingly, because we ended up with 2 national databases and duplication of effort, there was a BPSU PIMS TS registry alongside AZARIC. Actually, that became quite important to UK Health Security Agency in order to be able to look at the data in real time, because of the way that AZARIC was set up as a research study. And as you know, BPSU is easier to get the data in real time if you with a bit more control. So our aim for recovery for inflammatory syndrome was to compare steroids with no additional treatment in the presence and absence of immunoglobulin. And immunoglobulin with no additional treatment in the presence and absence of steroid. And this, again, was a decision that we had to make at the time. Recovery very much is set out against standard of care. And although it was questioned by many in the paediatric community, the reason why we did the Delphi was because there was question, would paediatricians enroll to standard of care if there was this push to treat children with inflammatory disease? Actually, the general paediatricians were saying that we need the no additional treatment, because many children with inflammation are coming to general paediatric wards, they're not needing treatment, and they're going home, and so we do need that no additional treatment arm. But this caused us problems, it really did, because it meant that the equipoise, when people were dealing with the most sick children, who were the most children we enrolled in the study, became confused in people's minds, and people would often go off protocol in a pragmatic way, like they're allowed to do in recovery. But that has given us a problem analysing the data, because we haven't got clean enough data to properly distinguish between the IVIG and steroid group. So while all of that was going on, I'm not going to read out all the spectacular adult results that changed the management of adult care, but also changed the management for children, because we weren't giving azithromycin or hydroxychloroquine or convalescent plasma to children because recovery had shown they were not benefiting, and in some cases hydroxychloroquine actually doing harm. My first sort of side issue here is that, this is another opportunity to say, look, the Americans really did have a bad pandemic, and their bad pandemic and the way the FDA behaved is impacting our ability to do trials differently going forward in the future. More about that later. Because, of course, the Americans had approved hydroxychloroquine and azithromycin and convalescent plasma for use in clinical care in the absence of any clinical trial. Quite outrageous, actually, if you think about it looking back. So this was the recovery trial in the bulk of our recruitment to inflammatory syndrome when in February to May 2021, after an amendment that let us separate the analysis for children from adults and put a formal Bayesian analysis on the paediatric data, which was clearly much smaller numbers, which had always been the plan from our intensive care colleagues who'd been thinking about a different study. But it did take quite a long time, 7 or 8 months, to convince the CIs of the study that actually we needed to have a separate statistical analysis plan for children. So that gave us, at the same time, an ability to add anakinra against tocilizumab against no additional treatment for the second stage randomization. And I've just told you that. We also, at the same time, added a follow-up questionnaire so that we could follow up people who'd had children who had inflammatory syndrome with the echo result and standardized quality of life questionnaire. So those pretty much were the trial treatments for children that we took through to the end. I won't go through all the different scenarios, but by the middle of 2021, it was clear that recovery was still the only global RCT for COVID-19 treatment in children. Other countries were considering opening a protocol alongside us, and actually Switzerland managed to take the recovery protocol, get some funding from a charity, and open recovery almost identical to us, but without the standard of care option. So they've compared immunoglobulin with steroid in about 60 patients before they closed, and we're hoping that we'll be able to submit the randomization 1 Bayesian analysis for children in the UK to the same journal at the same time as our Swiss colleagues who are in the process of analysing their data as well. Certainly the largest global RCT for PIMS TS, and in the middle of 2021 we'd enrolled 278 children from 64 hospitals and 5 neonates at the time. By the time we closed the study to recruitment to analyse in August 2021, the final number of children is 337 from 69 hospitals and 8 neonates. At that point, we were all pretty excited because there were new flu arms that had been approved by Ethics and MHRA, and there's about 4,500 flu admissions with children of all ages in the UK every year when there's flu. But that got stuck. That hasn't been implemented in the overall DHSC, government, UK Health Security Agency, NIHR funding melee, which is now. And that never got opened, but we are still hoping as a community to work to get a similar protocol with for recovery open for children of all ages with influenza for future years. Charles Rowe is going to be really critical to that as the Deputy Director now of the MPEU in Oxford, because they hold all the study systems for recovery. More of that in the future if we manage to achieve funding for recovery influenza for children. It doesn't seem sensible to anybody to go through the whole hassle of a completely new protocol with a new CTU and set up again every unit if we can manage to do it on an amendment in a new way. But none of that is all of that is aspiration at the moment, not funded commitment. So in terms of how we treat PIMS-TS in children, inflammatory syndrome, other people, both in the United States and in the United Kingdom, had been doing large sort of retrospective cohorts, and a French study, published in JAMA, showed that IVIG and methylprednisolone against IVIG alone was associated with lower rate of treatment failure. You can see here the problem. Nobody was not giving IVIG because they were worried about Kawasaki-like disease, which turned out in the end, I guess looking back, to be distinguishable. And in the end, we just didn't enroll children under 5 who looked like they had Kawasaki's in recovery. It's a different condition, but nobody really knew that at the time. And there was anxiety particularly driven from the United States, but paediatricians in the United States, sensible people, not the FDA. And Mike Levine and the Imperial College Group's BAT study, which was, again, retrospective global study, very complicated analysis, also showed very similar. Not much difference between IVIG and steroid and, steroid and steroid. I'm not going to try and explain that, but you can see all the different treatments just about on this slide. That this is in the New England Journal, and how complicated that is to have analysed in a retrospective analysis. So I'm going to switch now to vaccines, and just remind you that at the beginning of the pandemic, a lot of this stuff wasn't known to the population. That coronavirus was a new virus. It had a spike protein, and we needed to know. There had been no licensed coronavirus vaccines before, and actually always very difficult to make respiratory viral vaccines. But we knew, as vaccine community, that whatever we were testing had to be able to produce antibodies and memory. And we knew that boosters might be needed in the future, but not how they might need to work. So what we needed to know about any new vaccine was, are they safe? And take a new condition now, it's exactly the same. Does it make an immune response? Do they protect against infection? And how long does that infection last? And are different technologies best combined in sequence, i.e. mix and match? This is a slide from May 2020. So, we were thinking, do we need to do mix and match even then? And will boosters be needed? And if so, how often? And so, the story of the Oxford study is that Sarah Gilbert, Tess Lamb and others at Oxford just got on with it, started using their adenoviral vector technology to design a vaccine that they had previously done a phase 1 trial in adult SARS-1 disease in the Middle East. So they had some data that they thought they could generate immune responses with this platform, and they opened in April 2020 outside Oxford. We were the first centre in Southampton to join the trial, and then 3 other sites joined. And this was, I guess, one of Southampton's biggest contributions to the pandemic was to take our recruitment model into a sports hall, have different floor plans for, in a pandemic, to have different floor plans for screening days and for vaccinating days, needing 67 people to enrol 100 adults and elderly adults a day, and then take this out and share it with all the NIHR regions and devolved nations as a way that we could get the mass immunisation done. the phase 1 study showed really encouraging neutralizing responses. And so the Oxford team carried on, got manufacturing ramped up, and started the COV-002 phase 2-3 trial, which had within it specific cohorts of adults and older adults, all of whom we did in the phase 2 in Southampton, because Oxford had a younger population, Southampton had an older population, and that eventually enrolled 10,812 people, adults, under Andy Pollard's leadership, but alongside 3 international trials in South Africa and Brazil that were also included in the overall analysis. So for COVID vaccines at that point, the Vaccine Task Force in the UK, led by Kate Bingham, set out to make sure the UK had access to whichever technology was proven. And so the adenoviral vector vaccines, replication incompetent, so safe to use in immunocompromised people, were developed. And just telling you a little bit about that, these are a well-established platform. I don't know why that pointer's pointing, because I'm not touching anything. But a well-established platform, including, just as an aside, for monkeypox. So the MVA vaccine, which is not the platform, it's a chimpanzee adenoviral vector for the Oxford vaccine and a human adenovirus for the Janssen vaccine. But the MVA vaccine is the basis of many vaccines in trial, including the basis of the current licensed smallpox vaccine, which is being used to prevent monkeypox. And so viral vectors have been used many times. They're easy to manipulate and produce, well-established safety profiles and enhanced stability. Thank you, pointer, whoever's controlling you. And they induce a memory. They induce both arms of the immune response with high levels and longevity of protein expression. And were being used and are being developed in children. So both Janssen and GSK pre-pandemic had adenoviral vector vaccines for RSV in clinical development for infants. RNA vaccines clearly were new technology for infectious diseases, but again, old technology for cancer vaccines, for testing as immunological manipulators and vaccines against cancer. And in fact, one of our studies on the clinical research facility in Southampton, led by Christian Ottensmeyer, since about 2014 has been testing the BioNTech one of the BioNTech cancer vaccines. So not new technology that we knew how to use in trials, but new to infectious diseases. And these take a piece of RNA that translates to the spike protein. The RNA doesn't enter cell nuclei, but it does enter the cytoplasm and create a spike protein that the human immune system can respond to. And it's quite easy to make and quick to make, but the technology that let RNA be used as a vaccine was the discovery of conjugating or linking up with lipid nanoparticle, which both acts as the vehicle to allow the RNA to get into the cell cytoplasm without destruction in the body, but also is a very important adjuvant for the immune system going forward. That's quite complicated immunology, which I'm not proposing to go into in any more detail. But the adjuvant function of the lipid is just as important as the RNA itself. And then also relevant to children in 2022, we were testing the recombinant spike protein-based vaccines, particularly the Novavax vaccine. Paul Heath, another paediatrician from St George's, led the adult UK trial of over 16,000 participants. And this is where the spike gene was inserted into a baculovirus there on the left, and then cells system infected, and the artificial system produces spike, which is then joined into with nanoparticles to make and matrix M adjuvant to make the Novavax vaccine. There's also the Valneva vaccine, the inactivated viral vaccine, old technology that you will know has now has also approved based on a study led by yet another paediatrician, Adam Finn, in Bristol in the adult world. And that was going to be built in a factory in Scotland, but when it became clear that there were concerns about whether it would be able to act as a booster after RNA vaccines, and adenoviral vaccines from the COV-BOOST study, the clinical development of that vaccine hasn't proceeded in the United Kingdom, but does proceed with Valneva and elsewhere in the world. And that, business decisions were being made by government all the time regarding, which vaccines would be useful to our population in the future. So back to 2020, and November the 9th, 2020 was a pretty amazing date, because nobody had ever imagined that vaccines would have 95% efficacy. And remember, this is just the first couple of months after the second dose, after another couple of weeks to give the vaccine time to work. But that still is way higher than anything for flu. And I guess nobody really believed Pfizer until Moderna reported the same a week later. And then Oxford again reported also over 90% efficacy in one of the dose regimes. At the time, there was a lot bad press coverage and hugely disruptive communication, particularly from the French Prime Minister and others, and confusion, perhaps not so good communications from the UK health research system and government, that actually the efficacy was different and the different doses of the trial had been different because it was being developed so quickly and because manufacturing processes had changed from factory A in Italy to factory B somewhere else. And there was no mistake made about the dosing, and built into the study design, all those different groups I showed you at the beginning were testing the different dose regimes. None of that came out in the communication around that Christmas. It's probably the first time you've heard that. But it did look as if the doses were responsible at the beginning, and that the low dose, that it was due to a dose. But actually, it turned out that was due to the better efficacy of viral vector vaccines was due to the longer interval between doses. So JCVI knew this, and they made a really important decision just before Christmas 2020 to increase the interval between doses of in the UK to 12 weeks. We think that saved 30,000 plus lives by doing that, and decided on the priority groups, immunising the most vulnerable first and working our way down. And around that time, without going into the detail, side effects were noted after mass deployment, both extremely rare blood clots after AstraZeneca and Janssen. And Janssen, incidentally, have now had a label slapped on by the FDA that you can't use Janssen in the United States without RNA being contraindicated. Completely mad if you look at our later COV-BOOST data, which I'll just tell you a little bit about later, and mad for the developing world where the Janssen vaccine is really useful because you don't have to give it so often. And the messaging around that United States decision is really quite outrageous. And of course, myocarditis in young people after Pfizer and Moderna, just showing us really that for very rare things, we need active surveillance, which we have in the United Kingdom and in Europe, and they don't do so well in the United States. The Winton Centre, you'll remember these slides, again, for time, I won't go into them in detail, did a really good job of trying to explain to people through the media, the risks of vaccines, despite these reported side effects, were staggeringly low and incredibly low compared to the risk of COVID. However, for pregnancy and children trials, the side effects ground us to a halt. We had started Janssen and Pfizer trials in the UK in pregnant women, and trials in children for AstraZeneca and Janssen, and they were well underway and very popular until the side effects and a pause in the studies at the time, because we didn't know what was going on. We didn't know how common those side effects were, and children weren't dying of COVID. So we certainly shouldn't be testing something with potentially rare side effects unless we knew the mechanism and what was going on. And around that time, the National Immunisation Schedule Evaluation Consortium, mostly led by paediatricians, Matthew Snape in Oxford is the chair. We're involved in Southampton, Bristol, St George's. The people who'd been CIs for the commercial trials. The NICEC was asked by DHSC and Vaccine Task Force, and NICEC used to do scheduled trials in children and infants and neonates. That was our business before the pandemic and hopefully back to after the pandemic. But we were asked to do the mix and match trials. COMCOV 1 and 2 were different mix and match in adult schedules, and COMCOV 3 for children, which I'll show you about in a bit. But also Bristol led the COMFLUCOV study last April, May, very rapidly proving that you could give flu and COVID vaccines together. St George's led PregCov and still do. That's just moving into boosters, and the pregnancy COVID vaccines in pregnancy, and Cov Boost is clearly the booster trial that for third and now fourth doses, and the bivalent Moderna vaccines about to be trialled in Cov Boost against Pfizer, because the companies, again, because the regulators currently can only do homologous studies, which is not greatly helpful. So Cov Boost was quite a complicated design. We led it from Southampton, but 18 sites across the country, now 19 with an extra site that joined, and published in the Lancet last December, had already been presented to JCVI and Vaccine Task Force in August. So very rapidly delivered across the system. Takes a long time to get all the data to publish a clinical trial when the labs are told, quite rightly, to focus on the vaccines that will actually be available. So we had to wait a long time for all the Valneva, CureVac, Novavax data, because actually the labs were focusing across all our assays that are reported here on the RNA vaccines and adenoviral vector vaccines, which were going to be available in the autumn. And the policy decisions that have been supported by Cov Boost were to use RNA vaccines as the third dose booster programme. The adenoviral vectors would have been just fine, but there was an anxiety about the headaches. If you give people an adenoviral vector and they get a headache because they've got a fever, they would have gone to hospital. And at that point in the pandemic, they'd have had to be put in a CT scanner looking for the rare thrombotic disease. So that was, pretty much the reason why RNA only was chosen for the booster programme. The 3-month data, the 3-month interval to our third dose was actually a problem for us. We thought it was too soon and was one of our limitations in our paper, but was really useful when Omicron came along and people needed to say, well, is it safe to give a third dose booster so soon after the second dose? We had done 3 months in the Cov Boost trial, and our data was used to communicate to the public that maximum antibody levels were reached by day 7 after a third dose, of which was mRNA after Pfizer or AstraZeneca, and that was worth going and getting your vaccine quickly because it would only be a week before you were protected. And clearly, our data has been incorporated into WHO heterologous vaccine guidelines. So ongoing, we're tracking people who've been in the study, and we've been looking at fourth doses, both of wild-type Pfizer vaccine and just about to start the Omicron variant. And why am I bothering to tell you a bunch of paediatricians and neonatologists about the sort of ongoing Cov Boost data? It's because of the clues it gives us to how we might use vaccines in the future for children. So when we got to 3 months in the Cov Boost study, we were able to show that the persistence of the antibody responses was different between the vaccines. Because, of course, the companies never do heterologous studies. But after AstraZeneca, the RNA vaccine still had the highest immune response. But after RNA, suddenly, AstraZeneca and Janssen were both highest antibody levels. So actually, the best schedule, if you're an adult, is Pfizer, Janssen, closely followed by Pfizer, AstraZeneca, or Pfizer or Moderna, roughly about the same. But that tells us that actually testing vaccine classes together becomes really important for the future and for all children's vaccines as well, because doing things in a mix and match way can give you higher or maybe more prolonged immune responses. We're just analysing our day 242 data to see whether it does last out to 8 months. So I can't tell you whether it goes beyond 3 months, but this is really quite interesting data for the future of how we test vaccines in children. And we also, again for children, showed that half-dose Pfizer and full-dose Pfizer were identical. Again, just making the point about the safety in vaccines, and I'll come back to the children's data in a few minutes. It was clear that Pfizer and Moderna had both picked doses at the beginning that were going to work in those adult populations. It was not so clear to anybody whether actually those doses could be less, either for the first 2 or for ongoing and subsequent doses. And it could be, as we go forward, that the myocarditis is a dose response. And actually, by using less vaccine in different groups of people or different ages, we might be able to reduce that risk of rare side effects down to nothing. That's important because we actually really would like to use RNA for CMV vaccines and RSV vaccines and everything else we want to do in children in the future. So understanding that dose response and mechanism is really still very, very important. I won't show you the data. I've just told you this, but this is our Pfizer comparison line. This is people given Pfizer, and this is AstraZeneca and Janssen best at 3 months. The Moderna is a bit artificial. Moderna is very high, but we used the full dose of Moderna in our study, and the original cough boost data had led to half dose Moderna being used in the national programme. So you have to just treat that with a pinch of salt, because in real life we've only used half dose Moderna as a third dose. And then the fourth dose study, around after 7 months following third dose boosters, we were asked to test the Pfizer wild type vaccine as a fourth dose. And this is interesting for children because although it shows that fourth doses can be safely given to adults, actually it shows that there does appear to be a ceiling that might be vaccine itself related, rather than just being able to boost and boost and boost. So again, indicating the kinetics of different classes of vaccines are different given at different times, and something we need to investigate for children going forward. So for vaccines as a whole in adults, we've got lots of work to do about optimizing protection in different age groups and people, addressing viral mutation issues, addressing the global manufacturing chain. That's actually been pretty well addressed. The problem in Africa now is uptake. There's plenty of RNA vaccines. There's plenty of vaccines, but giving them in a hesitant population is really, really hard. And the travel issue, letting people who take part in trials travel without certificates, has given us massive headaches, and I won't dwell on that here. For the Oxford vaccine, by the end of last year, over 2 billion doses had been administered at cost, which was absolutely staggering from the Oxford team. And globally, despite America still not having approved this vaccine for use in the United States. So last summer, we had a dilemma for children and pregnant women. The pregnancy studies had all paused. Pfizer was still going, of course, because it's RNA vaccine. PregCov had switched to using Pfizer, but pregnant women were really not coming forward for trials. And in your world, you'll know this, really not coming forward, causing for immunisation. Very different to flu and whooping cough, and something that we're still struggling with today. And we had no trials in the UK going on, but the RNA vaccines were being trialled in the United States. So what dose were we going to use? What was the side effect profile? For children, and the issues at the time last summer were that children don't get severe COVID-19. Long COVID incidence in children's unknown, but at the time was thought to be smaller than adults. And would vaccines in children be deployed for individual protection or to prevent further transmission? Because there was a lot of people thinking, oh, these really high efficacy, 95%, we should be able to stop transmission. But then the vaccine, the virus is mutated, and it became clear that actually the phrase breakthrough infection was really wrong to have used. Why should these vaccines be 100% effective? They're not 100% effective for anything any other respiratory infection. And it's not really breakthrough infection, but the fact that COVID vaccines we now think of in the vaccinology world as preventing severe infection and death and hospital admission, rather than preventing transmission. But a lot of people were saying we've got to immunise children to stop transmission, which wasn't really true for Delta and is definitely not true for the different forms of Omicron now. So what was the thinking around that time? Immunocovid and all the other specialty-based databases were still not worried about children's severe disease. Publications from national cohorts for deaths in children and PICU admission, again, not worried. In Australia, again, not worried about severe disease in children towards the end of 2021. Low incidence of inflammatory disease that seemed to be going away with subsequent variants, and certainly seems to have gone away now with Omicron. Second Isaric paper showed for children less antibiotic use, less oxygen, less ventilation, no changes in oral or IV steroid use. So really, there's not much pressure for children's disease for COVID. And available from last week, actually, still as a preprint, is quite an interesting paper from UK Health Security Agency that looked at all the COVID-19 deaths in children and young people in the UK from March 2020 through to December 2021, linked with clinical systems, went back and did studies with did questionnaires with the clinicians, GPs and hospital doctors where there had been a case and adjudicated independently whether COVID contributed to death. And again, a staggeringly small number in a pandemic of deaths actually due to COVID in children, confirming what we all knew as paediatricians, that severe COVID really doesn't impact children. Sure, every death is a disaster, but in a pandemic where you might not stop transmission with a vaccine, is this, the data, this data doesn't push us to immunise children for their personal protection. But what about long COVID? Clearly, lots of different reports about long COVID and a very loud voice saying long COVID's got huge rates in children just like adults. And Terence Stevenson led a UK collaboration called the CLOCK Consortium, which set out to and was funded to investigate prospectively what the rates of long COVID are in children in the United Kingdom. They did just before their systematic review was published, the Zoe data came out, 60,000 children in the Zoe database. Again, long COVID was present, but in a rarely in children. Was reported, but not the debilitating illness that adults were reporting on the same scale. Sure, just like after Lyme disease or glandular fever or after CMV, and a lot more children are getting those all at once in a pandemic. Sure, all of SARS-CoV-2 can cause a debilitating post-viral syndrome in children, but it appeared to be less than in adults. And the CLOCK study, big collaboration, won't read them all out, also showed this with their first paper that's been published in November in the Journal of Infection. So I won't go through the data, I'm sure you've seen it. But what was really important was that at 3 months, yes, there were a few more symptoms in the people who'd had COVID, children who had COVID compared to those who didn't, but actually they were at school. They weren't debilitated at home, unable to go out of the house. They still reported a bit of a cough, or they were back to their activities of normal living. And buried in the supplementary file, was a couple of things. Well, in the main data, multiple symptoms were more frequent among test positives, females, older children and young people, and those with worse pre-test physical and mental health, maybe not surprising. But buried in the supplementary figure 1 was that a third of children, regardless of whether they had COVID, had mental health problems at that stage in the pandemic. And that wasn't different between groups. So really worrying, and a Danish study published this week in Lancet and Child Health has also shown very low rates of genuine long COVID, but multiple symptoms in some children, which now the CLOCK Consortia have published a research definition of long COVID and will take forward studies for how we might investigate and treat long COVID in the future. So important topic. It's not insignificant, but it's not as big as in adults, and it needs investigating specifically for children. But it's not a reason to immunise in a pandemic because the numbers are still small. So very quickly in the last 5 minutes, I must speed up because I hadn't realised quite how long this would take. The vaccines we've got for children 12 to 16, for 5 to 11, they're now approved, and the UK implemented vaccines for children for parental choice for the reasons. JCVI did not want to implement children's vaccines, find there was a problem, and then have the entire immunisation programme for children distorted by people saying, well, you've given vaccines that are harmful. And from the data I've showed you, you can see why they made that decision. It really wasn't a sensible use of our resources in the country to divert them to immunise children. And this week, maybe quite bizarrely, but under public pressure, again, the FDA have authorised these vaccines down to 6 months of age to be deployed if people want them. The data's there, but Moderna did their studies really well, and the most exciting thing about the Moderna data is that RNA vaccines work and appear safe in small groups of children in these studies. When Moderna said to me, aren't you excited about this? I said, no, not really, because we're not going to deploy them in Britain, but I'm really excited that you can use RNA in children down to 6 months, because that really gives us hope for the future about your programs. And Pfizer didn't do their trials properly. They just went with 30 micrograms, and the FDA let them get away without a dose-finding study. And when this was pointed out to Pfizer last September that it was pretty unethical, they went back, because when they published their first paediatric data, 5 to 11, actually it was exactly at 10 microgram doses, it was better immunologically than the 16 to 25-year-old 30 mic data. So you can say, well, why hadn't they done the 10 mic study in teenagers before they went ahead and deployed it? The answer is they didn't, and the FDA let them off the hook. Catastrophic, actually, for children's immunisation, and Pfizer, I don't mind saying, should have done better. Their data was published, showed high effectiveness, but again, very quickly, for the very few weeks after the immunisation, and then it waned, just like all the other vaccines with Omicron. The side effects and risks are no different from any other vaccine, but myocarditis was noted in the US, UK, and Israel. Data from everywhere was saying that young people, particularly teenage boys and boys in their 20s, men in their 20s, were getting a myocarditis, not insignificant, and would take people into hospital. And there was a study that was in paediatrics that the data caused JCVI some anxiety, because there was initial data that JCVI had seen showing that there might be longer-term MRI changes in people with post-vaccine myocarditis. Now, this hasn't turned out to be a massive problem, but it just contributed to what I would say is completely reasonable JCVI decision-making last autumn, not to go ahead straight away and immunise children with the high dose 30 mics of Pfizer, which was available at the time. And there's UK and US data if you're interested. COMCOV3, led by Matthew Snape, the mix and match children's study, was set up, first of all, to look at different vaccines, so Pfizer and Novavax. So the first 2 doses last year, Pfizer low dose, Pfizer Novavax in teenagers, and then now we've changed the protocol, recruiting now and into the autumn, to look at whether Novavax or low dose Pfizer should be used as boosters, mix and match in children. So children won't be offered boosters in the autumn, so we should be able to recruit and complete and get this data. And then, of course, other vaccines available might be available, or different doses to use as boosters in teenagers without potentially the risks of myocarditis or other things. But children have immunity already. So what's the story? Again, another Matthew Snape-led study showed last summer that 45% of children had anti-S antibodies. And through the different waves of the pandemic, August to September, October to November, it was clear from the ONS survey data that loads and loads of children had COVID already, despite no immunisation. And to cut a long story short, in January, the seroprevalence ranged from 90 to 93% in teenagers and 60 to 72% in 8 to 11-year-olds. So we already had really good levels of baseline immunity in children without wide immunisation. And the politics and loud social media was too much. And Chris Whitty thought, OK, well, for education, the vaccines might get people back to school a day or two earlier if they've got symptoms. It's just not worth the politics of not immunising. But, why should we immunise children? Risk of death, risk of serious illness, inflammatory syndrome, long-term symptoms. If we could interrupt transmission, protection of education. There were some mad political decisions about travel. And if children had needed vaccines to travel, then fair enough, that might have been a reason to offer it. But, there are lots of different reasons not to immunise children. Mild disease, already immune, less interruptible. But really, the resource prioritisation is the issue. If we divert resources to immunising children for COVID, we're going to take away from meningitis vaccines, HPV vaccines, and the routine immunisation programme. It's not a good cost-benefit analysis for us in the United Kingdom, or probably anywhere. So, it would be bonkers to mandate vaccines for children, and there's recommendations are rapidly evolving. I've already, mentioned that there was a decision to allow parental choice, which is reasonable, although some people were uncomfortable with that. The JCVI estimate that a future severe wave of COVID-19 would need to vaccinate 1 million children with 2 doses each and only avoid 58 hospital admissions, of which 3 would be ICU admissions, to put some real numbers on what I've just been telling you. This is pretty sad, and it's sad for the future of vaccines and public decision making, and has led to government anxiety and anxiousness and anger about JCVI. So we'll have to see how JCVI is treated by the current government going forward. And of course, the ongoing arrogance and poor decision making of a major global regulator is a massive issue. So very briefly, if I can, quickly. So lessons from the future. The regulators are phenomenally important, and our ethics service. They've let this happen. Absolutely brilliant team at the MHRA. The Vaccine Task Force, the national network decision, and the vaccine trials we've successfully delivered, and the heterologous trials and recovery and the low risk bits of recovery, that approach made the difference globally for treatment and prevention of COVID across the world. Right? mRNA was done in the United States, fair enough, but all the treatment trials came from the important ones came from the United Kingdom, and AstraZeneca was the most deployed vaccine globally. In the UK, 50,000 people in COVID vaccine trials in 25 studies, over 1 million people by the end of March 2021 in COVID research, over 2.5 million by the end of January this year. Absolutely staggering effort by NIHR. So for the future, enablers and barriers. That communication with regulators and ethics was really important. Constant, weekly, emails, advice, maintaining their independence, changed our protocols in real time so that we could generate the data for policy making. They were responding to the technologies and clinical need. We need, going forward, to address the fixed belief of the system. We need our American friends and colleagues to stop thinking they're so expert they know what to do and do things without trials or do trials in the old way. When the MHRA invited me to present these last 5 slides to a meeting of global regulators about pandemic work, really good discussion and buy-in from Canada, Europe, Japan, Australia, UK. Total silence from our colleagues at the FDA on the line. They just don't get how bad their system is. Our national ethics system is hugely beneficial, and of course our national sign-off. One thing that is clear, and you must be affected by this as much as we are in older children, is that the CROs are not fit for purpose. Intermediate clinical research organisations are a barrier. Their electronic systems don't work. Their people are badly changed. Their business model focuses on making money, not on the best trials for patients and pharma. As one example, and I could give you hundreds actually now, a system failure from IQVIA, and I've told them I'm going to present this because they still haven't sorted it out, led to 3,000 Ensemble 2 patient visits being cancelled, having been made in the United Kingdom in November and December 2020. That's the Janssen phase 3 trial. Absolutely outrageous, and pharma have to sort that out because they pay the bills and they're too chicken to do it. For infectious diseases, I've already sort of implied this. For children, this is really exciting because actually the heterologous mix and match schedules might be better and they might be safer. And we know that our regulator is happy to discuss that and work out how to do it. We know that some of the companies, Moderna, Janssen, others, Sanofi, have indicated that if they're told by the regulator to work together, they'll do the trials. The FDA are blocking this because they can only see homologous, the old-fashioned way of doing studies, as the way forward. So we somehow need to address that. And for antimicrobials and all the other things we test in children, working out how to do things better from a patient perspective is really important. We need the risk-based approach that recovery used. It's really important. Most trials are low risk and don't need all the paperwork that we're committed to do that use up your time and our time. And industry's got a big responsibility to share training platforms and systems to avoid duplication. Some of you might have signed up to the SIP, the Single Investigator Platform, that UK Pharma through ABPI signed up to all 5 years ago, and then they all use it in different ways, and they just use it as an extra platform that everybody has to fill in their forms on and training on, rather than everybody looking at everybody else's information. And it's not just about pandemic trials. The good future is a partnership, not us and them. Research, regulators, public sector, industry. My last comment, I'm not going to show you all the slides, is that this is in action. There's a study that's about to happen called Harmony in the UK in infants under 1 year old, including babies, that has used this experience, and it's an industry study, and Sanofi have listened to all of these issues. Nirsevimab is a monoclonal antibody you might know, you might have seen the New England papers, that is now going to get a license for the prevention of RSV and replace palivizumab, because it's a single injection per season. So the phase 3 studies in the New England Journal, the phase 2 studies in the New England Journal, they didn't meet because the pandemic and they had to stop early. They didn't meet the hospitalization outcome. And Harmony is set up to address that question. They came to us in September last year through a group in Liverpool, but linking up with us in infectious diseases. And they came to us and said, we want to do a 30,000 study. Here's the concept protocol. It's a standard vaccine trial with 6 or 7 visits with lots of swabs. We said, you can't do that. It's going to be impossible in a post-pandemic world. Nobody would be able to set it up. Everybody will say no. But they were prepared to work in a new way, including giving us pump priming for all the LCRNs are getting £100,000 early. So Sanofi went, OK, costing template. You need an extra 100,000 per region to get people in place. We'll give it to you. So that's now being distributed. And they came to us with their protocol, standard one, in January. It took them that long. We put a bunch of red lines on it and said they needed startup funding. We're going to help you choose the CRO, which they let us do. It's now LabCorp because they have to work in a different way. All the systems are IT friendly. They took the protocol advice. They pre-discussed with ethics with us. They have a weekly management meeting. And Harmony is going to open single visit study. One group are going to get nirsevimab and one group are going to get nothing without an injection, with no placebo. 12,000 in the UK has its own independently powered outcome for hospitalisation. The 30,000 across Europe is to take that even higher. There's no investigations. There's one visit, one injection, all the follow-ups online. And parents can just fill in diaries with a UK-based call centre for investigators to take all the queries from patients. So only babies with real problems will be sent to hospital. Endpoints and inclusion and exclusion criteria are as we would expect. So that's Harmony, which is the learning from the future. So thank you to everybody in the recovery acknowledgement group, everybody in the recovery group, all the UK studies that I've mentioned as I've gone along, the CovBoost study team, and to you for listening. And I'm really sorry I've run a bit over because I thought you'd want to hear about Harmony at the end.
Saul, thank you. That was an amazing tour de force and a phenomenal overview of just how much effort and innovation the UK contributed to all of this. Time has beaten us, I'm afraid, but I hope you will stay with us and join us for lunch. And anyone who has any questions for Saul, I'm sure that there are lots of questions we can
happy to
catch you at lunch. But thank you so much for a fascinating keynote. Thank you.